Hello, I'm Michael Oken, Chair and Professor of the Department of Neurology and the Co-Director of the Center for Movement Disorders and Neurorestoration at the University of Florida in Gainesville, Florida. Welcome to this program. It's on treatment options in Parkinson's disease psychosis. Joining me today are Dan Kremens. Dan is the Associate Professor of Neurology and the Co-Director of the Parkinson's Disease and Movement Disorders Division at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, Pennsylvania. Thank you for coming, Dan.
Hi, Michael. Thanks for having me.
And also, we have Neil Hermanowitz, who's a clinical professor in the Department of Neurology and the Director of the Movement Disorders Program at the University of California in Irvine. Neil, welcome.
Thank you. Happy to be here.
Before we begin, I'd like to note that this program will include discussion of off-label uses of therapies approved by the Food and Drug Administration, the FDA, for use in the United States. In addition, this program will include discussions of investigational agents not yet approved by the FDA. The goals of this program are to review the current management strategies for Parkinson's disease psychosis, to outline the risks of antipsychotic treatment in Parkinson's disease psychosis patients, and to review the data on emerging pharmacological treatments for Parkinson's disease psychosis. So let's start off. First, Neil, tell us a little bit about what is Parkinson's disease psychosis. What does that mean?
Psychosis in Parkinson's disease consists most commonly of hallucinations, which are, again, most commonly visual in nature. They can also be auditory, not very common, sometimes olfactory, sometimes tactile. With that also there can be delusional thoughts or ideas that are not reality-based. My spouse is misbehaving, people are trying to take my money, that sort of thing.
Dan, you see a lot of Parkinson's patients in your practice. Do you see a lot of people who have hallucinations? Is this common?
Yeah, so I think it's thought that up to 50%, or at least 50% of people with Parkinson's disease will experience Parkinson's disease psychosis at some point during their disease course. I think the other thing that's really important to emphasize is that Parkinson's disease psychosis is different than Parkinson's disease dementia. Parkinson's disease psychosis can occur in people who are entirely cognitively intact. Whereas Parkinson's disease dementia really involves demented patients who may have psychosis. In fact, it's a risk factor for Parkinson's disease psychosis, but you don't have to be demented to have Parkinson's disease psychosis.
Yeah, I think that's a really important point, and important for people and practitioners to know that not everybody gets clinical dementia with Parkinson's disease. And so let's talk a little bit about hallucinations. So there's this notion about hallucinations in Parkinson's disease and that they're all benign. And you know, most of the practitioners who've been around a while will just leave them alone and not treat these hallucinations. Is this still the conventional thinking, or has research changed the way that we're beginning to think about this?
The idea of hallucinations being benign has largely been discarded. They may not be terrible at this moment, but with the passage of time, in all likelihood, and the data support the idea that they will become more intrusive, more disturbing, and can, in fact, go high on the list of priority of things that are troubling our patients, and their spouses as well, or their caregivers.
Yeah, it's interesting they mention the spouses because the way I think about this is a true story. One of my patients first came to me with telling me that when she was going to bed at evening, her deceased husband would stand by her. And she found this very comforting. This was this notion sort of benign hallucination. Well, it wasn't so comforting when about 6 months later the person standing by her was no longer her husband but someone breaking in the house, right, resulting in 911 calls. So right, this is the reason why we really have to take these things seriously. You can't just ignore them because very often they're a signal that something bad is coming.
And along that same line, they do persist. They are not a transient phenomenon. They persist and they tend to escalate in terms, as you point out, the severity, how troubling they are to people, our patients, or to their spouses or caregivers.
So for the practitioner out there, I guess they should know that there's now mounting evidence, both clinically from observations from experts like both of you, but also from researchers, from Dr. Getz in Chicago and other people, that are showing that benign hallucinations really aren't benign, because they can, as Dan said, turn into something that could be very troublesome and even dangerous.
Chris Getz studied a large number of patients and they followed them, and what they found was that by 3 years, 80% of the patients that they had been following who's had hallucinations that were initially benign were no longer benign, and in fact were troublesome or disruptive.
So tell me, Neil, when you encounter Parkinson's disease psychosis, when do you adjust the medications? How do you handle it?
I want to make sure that patients are taking a very economical regimen in the first place, and I hope I'm doing that already. But if somebody tells me that they're having hallucinations, and I ask actually at every visit of all my patients with Parkinson's if they're having these kinds of symptoms. And if I detect them, or if the spouse brings it to my attention, or sometimes the patient brings it to my attention, the spouse is unaware, I make note of that. I discuss it with patients. I look at their medication list, both things that I've prescribed and things that maybe other people are prescribing, or people are taking over the counter themselves. Diphenhydramine, sometimes people are taking at bedtime for sleep, probably not a good choice for somebody who's elderly, perhaps having hallucinations.
Dan, in terms of reducing medication, there's been lots of groups who have sort of laid claim to this is the way you should do it, this is the way you shouldn't do it. There's even some recent guidelines out of Europe that suggest, certain ways to do it. But is it your feeling that there's one way to do this, or is it an approach, that needs to be tailored for the patients?
So I think, as with anything in Parkinson's, every patient's different, and you have to take a different approach with each patient. I would say the first thing that I like to do, as I think Neil has pointed out, which is just critical, is the first thing you have to do is ask about these things. Because very often patients are not going to volunteer to you that they're having hallucinations. They don't want to be thought of as crazy. They're afraid, well, if I tell my physician or my spouse that I'm having these symptoms, I'm going to get locked up. So that's the first thing. Once you've established that, the next step that I like to do is make sure there's nothing else going on. As Neil pointed out, not taking any new over-the-counter medicines, any herbal supplements, haven't bought anything off the internet. Then I want to make sure nothing else like a urinary tract infection or pneumonia, something, particularly if these are coming up sort of acutely. Okay. Once we've ruled that out, and it really does seem like the patient is experiencing Parkinson's disease psychosis, I take a pretty stepwise approach to the medications, again looking at each patient individually. I'm probably going to start by seeing if they're on any anticholinergic medications, amantadine, and then of the MAO inhibitors, I find that selegiline, probably related to its amphetamine metabolites, may be a little more agitating, so I'll try and wean those. After I've weaned those, I look at the dopamine agonist drugs, particularly in an older population. They may not tolerate them quite as well as younger folks. And then backing off with entacapone or tolcapone if the patient is taking those, and finally leaving levodopa for the last medication that I'll remove. But I think a really important thing to remember here is, when I was in medical school, we were all really taught that the Parkinson's disease psychosis is really a result of too much dopamine, and if you just get rid of the medicines, that the patient's going to improve. And what we're learning now is that while dopamine may be implicated in Parkinson's disease psychosis, it's certainly not the only cause and probably not the primary cause. And sometimes removing all these dopaminergic medicines does not result in improvement of the psychosis. So there's something going on here beyond dopamine.
And may in fact worsen what we're trying to treat, which the motor symptoms of Parkinson's disease may suffer as a consequence of reducing medications. Again, I hope I'm creating a medication recommendations that are economical, that are not things that are superfluous on their list of medications. But when we start pulling away medications, they may end up with poor mobility, which is not going to make people happy as well.
And may in fact worsen the agitation that you can see with the psychosis, because now they're hallucinating and they can't move.
Right.
So it can be a real problem.
One of the take-homes maybe for the practitioners, who have to deal with these patients in the clinic is I have two experts and they're both saying simplify the regimens, make sure they don't have infections, and so sometimes the fancy solution isn't always the right solution, and when we think about that and you do all the things that you can to treat a patient, and it sounds like going through looking for urinary tract infections, reducing medications, getting rid of medications as much as you can, even maybe paying attention to not just the dose but the intervals. But once you've done all of those things, then you sort of end up with this question of, should you start a medicine for that? So Dan, how do you handle that idea, and how do you approach that?
So once I've made the appropriate adjustments and I've ruled out that nothing else is going on that could otherwise account for the psychosis, at that point I think it's appropriate to say this patient is having Parkinson's disease psychosis. And as I think we've emphasized, it's really not a benign condition. So I tend to have a relatively low threshold to treat these symptoms just because I know that they're going to evolve into something problematic with time. As you know, there are no FDA-approved medications that are currently indicated for the treatment of Parkinson's disease psychosis. So right now we tend to use medications on an off-label fashion. Typical antipsychotic medications are known to have marked worsening of the motor symptoms of Parkinson's disease, so I avoid those. I think a common misperception among many psychiatrists and perhaps even some primary care doctors and even neurologists is that the atypical antipsychotics do not affect the motor symptoms of Parkinson's disease. And with rare exceptions, this isn't correct. The atypical antipsychotics can affect the motor symptoms of Parkinson's disease as well. So we have to be careful in our use of those and our choice of those. So I think the atypical antipsychotic that has the best evidence for the treatment of Parkinson's disease psychosis without worsening motor functions is clozapine. The problem with using, and clozapine has been demonstrated in multiple studies to be effective for Parkinson's disease psychosis without worsening motor symptoms. The problem with clozapine is that it can have significant side effects. Primarily, the worst one is agranulocytosis or neutropenia, which can be fatal. In addition, all the atypical antipsychotics are difficult, may have serious implications in the elderly, particularly those with heart disease. So we have to be careful. But
and in fact have a boxed warning cautioning about sudden death in elderly people with cognitive impairment. That is something that everybody prescribing those medications should be aware of. And the patients that are receiving them should be informed of.
Right, and Neil, you and I were talking about earlier because one of the difficulties with using clozapine is that you have to carefully monitor the blood, and at my practice, it's very difficult. I don't have a sufficient staff to do that. I know, Neil, you do use clozapine.
We do, but it is a major commitment on the part of the patient and often their spouse as well as the office staff, because for 6 months it's weekly monitoring with weekly dispensing of the medication. After 6 months it's every 2 weeks, and after 6 months, if everything is okay, then it's on a monthly basis thereafter. That is a big commitment and often a stumbling block to initiating that medication. Patients hear that, their spouses hear it, and they go, how am I going to get around, how am I going to get to the lab and get all these things done? But we do it, but it's not a simple undertaking.
Right, so I think in my practice, since I'm not using as much clozapine, I tend to use more quetiapine. So, and I think in practice, that's the general atypical antipsychotic of choice. The interesting thing, though, is when you look at the data for quetiapine in Parkinson's disease psychosis, it's actually not very good.
Well, there are 3 trials, is my recollection, that were not successful in meeting endpoint in terms of addressing Parkinson's-related psychosis. So yes, it is the most commonly prescribed medication by neurologists, I believe, for that problem, despite the fact that the evidence is, in my opinion, inadequate or insufficient.
Right. There's only been one study, and it only had that was positive, and it only had 16 patients in it. So I think anecdotally, we use a large amount of quetiapine in this population, and I think, at least in some patients, we're seeing results on an anecdotal basis. But when you look at the data, it's really not there. And quetiapine also does carry the black box warning, so it's something that we need to be concerned about. What I see sometimes in my practice, again, because I think there's a lack of understanding, particularly among some psychiatrists and primary care doctors, is that they're used to using other atypical antipsychotics in their non-Parkinson's population, and sometimes with good effect. So medicines such as olanzapine or aripiprazole. But what they don't understand is that these medications are going to have a real effect on the motor symptoms of our Parkinson's patients. So
I've had that discussion with psychiatrists on occasion who have prescribed olanzapine to my Parkinson's patients, and I've told them there are data indicating that it does in fact worsen the motor manifestations of Parkinson's disease. It's not a good choice.
So one of the take-home points here, and this is a great discussion, is that I think practitioners, whether you're a family practitioner, a neurologist, or a psychiatrist, just realize that neuroleptics, or medicines that block dopamine, can worsen the Parkinson's symptoms, so we have to be careful. And there seems to only be a couple that might do the drug, and quetiapine, as Neil, as you point out, doesn't have the data really to support it, but it does seem to work in mild cases of psychosis, at least anecdotally, for a lot of people out in the field. And then, as you pointed out, Dan, clozapine is a great drug, but there are a lot of barriers to its use. There's a new REMS registry, and if you have access to it, it can be life-changing for some patients, but tough to get out there. And so there are, I think, issues when we start to think through the different drugs and the different treatments. I want to get back a little bit to a comment that was made by you, Neil, about psychiatrists. And so you have a psychiatrist that sees the patient, and the psychiatrist puts the patient on a drug because they treat hallucinations all the time. And so they see a hallucinating Parkinson patient, and they know that this could be a problem. And so they do the right thing and they immediately address it, but the right thing at the wrong time could be the wrong thing. So could you address that a little bit?
Well, it has been the source of conversation, telephone calls between the psychiatrist and me in terms of medication choice. And again, they get the psychiatry part very well. It's the Parkinsonism that I'm concerned about. And again, somebody going to olanzapine and their motor findings worsen. And I know it's the medication. So I've had to have these back and forth conversations sometimes with psychiatrists about finding something that we can both agree upon in terms of moving forward safely that both addresses the psychosis symptoms and doesn't make things worse in terms of mobility.
So it seems like, Dan, like just building on what Neil is talking about, it turns out that communication might be, check for urinary tract infections, simplify the medications, understand the differences between neuroleptics, but maybe the communication between practitioners could be an important aspect of management. Do you find that's important for your patients?
No, I agree entirely, and particularly because that this population, particularly once they've started to have these disturbing hallucinations, they're a fragile population. They're easily disturbed both from a psychosis standpoint, but also by a motor standpoint. You really have to be careful with the way you adjust the medicines.
It does require, I think, some experience and recognition of the complications of all these medications that we're using for these patients.
Yeah. One other medicine, Michael, that we didn't mention that I think, again, can be used in an off-label fashion that can be efficacious is rivastigmine patch, which does have an indication in Parkinson's disease dementia, but there have been some limited studies that have demonstrated that using an acetylcholinesterase inhibitor, particularly rivastigmine patch, may help relieve some of the hallucinations that we see in Parkinson's disease psychosis.
I agree. I know that data, but my issue, the problem I have using that approach is that's a slow titration.
It is a very slow titration.
Especially for a problem that may be escalating, that you're waiting for 8 weeks sometimes before a dose is reached. And that is of concern to me. So if I'm going to be treating Parkinson's psychosis, I want to have something that's efficacious and hopefully within not within a 2 or 3 month time period.
Sure, but one of the nice things though with using it is that people with Parkinson's disease dementia are at an increased risk of Parkinson's disease psychosis.
Right.
At least 75% of patients with Parkinson's disease dementia are going to develop Parkinson's disease psychosis. So particularly if the Parkinson's disease psychosis hasn't progressed to the point where it's interfering with life, when we are still having some of the so-called benign hallucinations, I look at that as an opportunity to use the rivastigmine patch, hopefully to kill two birds, right? Maybe improve their dementia a little bit and hopefully alleviate some of the psychosis. But I agree with you, almost certainly down the road, I'm going to need to add something else because it's not going to be sufficient. But as a first start in a demented patient who's not greatly disturbed, I like it.
And I think, Neil, I think you make a great point for the practicing clinician. We all know to take, for example, if we treat depression, we know if we start an antidepressant, we need to follow that patient up in 2 to 4 weeks and make sure that we titrate it up and make sure that we get control of the situation because there's a danger of suicide. Well, sometimes maybe we don't see that same urgency in psychosis, but what you all are telling me is maybe as practicing clinicians, we should take this as a more urgent problem before the benign, as you say, Dan, will start to transition to something a little bit more serious. Some of the treatment and patient characteristics that I think are important and points that you all have brought out is this idea that the atypical antipsychotics are not always benign. In fact, there may only be 2, quetiapine and clozapine at this point that are FDA approved that are appropriate. Some may not be appropriate for patients who have cardiovascular disease, and you have to watch QT intervals and things like that. And you have to assess the disease severity, and as Neil said, look out for worsening in motor symptoms when you're using these types of medications. But you know, there's so much focus on the dopaminergic system when we think about Parkinson. In fact, the knee-jerk response is Parkinson, and everybody just thinks dopamine. And when we think about psychosis, is the thinking still on dopamine, Dan, or have we shifted? And are we starting to think of it more broadly?
So, you know, when I was in medical school, really we were taught like Parkinson's disease is all about dopamine. But we're realizing now that Parkinson's disease involves many more neurotransmitters than just simply dopamine. And in fact, one of the real prominent ones coming to light now is the serotonergic system. So there have been a number of studies, both post-mortem studies, imaging studies, genetic studies that have increasingly implicated the serotonin or the 5-HT2A receptor in particular in Parkinson's disease psychosis.
And so, Neil, in your patients now, have you started to shift now? I mean, it's been, you've had many patients for many years with Parkinson. Are you starting to think of them differently when they present as this being not only a dopaminergic and disease progression issue, but also there might be serotonin at play here? Are you starting to think about that now?
Absolutely, and as Dan mentioned, there was a very interesting study out of the Toronto group looking at brains post-mortem and receptor binding for 5-HT2A, and so showed an increased binding in certain parts of the brain implicating serotonin in the pathogenesis of psychosis.
And I think what's really fascinating, there were PET scans, for example, in living patients where they gave them dopamine blocking agents, and in the PET scans you could see that they had blocked 90% of the dopamine receptors, and yet the patients still hallucinated. There's also been studies where we've given levodopa infusions to patients without worsening their psychosis. So this suggests that there really is something beyond dopamine involved here.
So I'm a bit of a novice when it comes to pharmacology, but you know, we're all taught that if you tickle a receptor, that's called agonism or agonists, and there are drugs that are agonists, and if you block a receptor, it's called antagonists, and that's about as sophisticated as I get on this issue. But when we get into psychosis, there's this thing called inverse agonists, and they may be an option for thinking about how we could get control of these symptoms as we develop drugs. Do you and can you explain a little bit about what an inverse agonist is?
Sure, I will. So we think we all know what an agonist and an antagonist are, but let's step back a little bit and just discuss those. So it's important to remember, and this is something that I don't think many of us are taught in medical school, that there are certain neurons that have basal activity. So even when the receptor isn't being stimulated, the neurons are firing. And serotonin or 5-HT2A receptors are one of these types of neurons. What happens with an agonist is that the receptor is stimulated and you get an increase in that neuronal signaling. What happens with an antagonist is, the way to think about this is almost like a dripping faucet. The faucet is dripping, that's that basal rate, and what an agonist will do will block the receptor but still allow that basal rate to continue. So you're still getting that dripping faucet. What's different about an inverse agonist is it shuts that faucet off. It blocks the receptor and stops that basal neuronal signaling. And that's the difference between an antagonist and an inverse agonist. It's that stopping of that basal activity, turning that faucet a little bit further and stopping that dripping.
So it's interesting that now as we start to think about Parkinson's psychosis, we think now on a molecular and neuronal level, and then that's helping us to think about different strategies. And
and the implication there, what's important with that, and it shows why we've been using the atypical antipsychotics. Initially, those were used primarily for their dopamine antagonism, but what we now understand, and what's probably actually causing the effect of these atypical antipsychotics, is that they're also inverse agonists for 5-HT2A receptors. So in fact, the antipsychotic activity that we're getting probably isn't related to the dopamine activity in those drugs. It's the inverse agonism they have. So you get inverse agonism with all the side effects of the dopamine blocking. So that's why we need a new class of drugs to address Parkinson's disease psychosis.
So in thinking about that, I know that this has been a quest of a number of different scientists in the field. There's been some recent literature on approaching this inverse agonist type of approach. Neil, can you update us a little bit about what we know about using an inverse agonist in clinical trials?
Well, as Dan points out, that this common feature of being a serotonin inverse agonist is found in many of the antipsychotic medications, including clozapine and quetiapine. That was motivation to try to develop a molecule that has that feature without the dopamine blocking effect, which is problematic for most of the antipsychotic medications in use of patients with Parkinson's disease.
And there's this drug called pimavanserin that has had several trials now that's has been directed at patients with Parkinson's disease psychosis. What do we know so far about these trials?
The trials so far have indicated that it does not worsen the medication. The drug does not cause worsening of motor manifestations of Parkinson's disease, and it does appear to be efficacious in reducing the psychosis symptoms of Parkinson's disease.
So do you think, Dan, an inverse agonism type of approach might be something that you could supplement with your patients at some point if this gains FDA approval? This is research right now, but is this an approach that you think is promising?
Yeah, so I actually think this is a really exciting area in a greatly unmet need in Parkinson's disease. Parkinson's disease psychosis can have devastating effects, not just on the patient, but on the family, right? If you have a patient who is delusional, who's accusing his spouse of having an affair, of stealing money, it has implications well beyond just the patient. It affects the spouse, it affects the children, it can affect neighbors. So this can have a real broad effect. So if we have a drug that can address the psychotic features without worsening the motor features of Parkinson's disease, this would really be a game changer. And hopefully pimavanserin, which has demonstrated efficacy in a number of studies now, will be that drug. It's currently in front of the FDA under consideration. So we're going to learn later this year whether the drug gets approved, but at least based on the data that's available now, I think that this should give tremendous hope to Parkinson's disease patients and their family that we might finally have a treatment that may improve their psychosis without worsening their motor symptoms.
For such a common problem associated with Parkinson's disease, as you mentioned, 50%, maybe more, as the illness progresses, and a feature of the disease itself, not just a consequence of dopamine medication to treat Parkinson's disease, but a feature of the disease process itself. Common and persistent and very troubling. I can tell you in my patients who have this escalating over time, it becomes number one on their list of things that are troubling or upsetting in their home life. The fact that their spouse is being accused of infidelity, or the medication you're giving me is poison, you're trying to kill me. These kinds of delusional thoughts, or the hallucination of people in their bedroom, and they won't go into their bedroom because they think there are strangers in their house.
So if we had to, sort of talk about some of the take-home points of Parkinson's disease psychosis, some of the things that we've learned is it's really important to identify it and make sure that you know that it's common, it can happen in your patients. Simplify the medication regimens, make sure there's not a urinary tract infection or something that might be unmasking the psychosis or bringing it on that's treatable. Remove some of the medications that maybe aren't necessary and could be contributing to the problem, but at the same time know that you're going to need to leave enough dopaminergic stimulation on to treat the motor symptoms of Parkinson. You've taught us that we need to be careful of the atypical neuroleptics or the atypical dopamine blockers, as Dan says, because most of those are going to worsen the Parkinson motor symptoms. And we talked about quetiapine is a weak drug, but a safe drug. And clozapine, also a great drug, a strong drug, but maybe a few too many side effects and a lot of barriers to its use, including the weekly blood monitoring. And so we have to think about where can we go, and a lot of the science now is looking at, can we develop drugs that maybe have the efficacy without the side effects. And so there's a lot of middle ground between quetiapine and even some of these cholinesterase drugs that can be used for treatment of mild psychosis to people that are very severe with clozapine. And so there's a lot of hope with the faucet, and maybe we turn off the faucet with an inverse agonist, and this may be a scientific approach that could be explored.
And also the shift away from thinking about Parkinson's disease psychosis as a problem of only dopamine, and an understanding now that the serotonin system is probably the main player in Parkinson's disease psychosis, with some implications for dopamine and perhaps some other neurotransmitters as well.
Yeah. And Neil, any take-home points for practitioners on this?
I think some pragmatic points, so that it is our job really to be asking about these things, because people, as you point out, don't volunteer these symptoms quite often. That's been looked at and reported in the literature, and it certainly has been my experience. When I ask, patients will sometimes acknowledge it, sometimes to the surprise of their spouse in the room. So asking about this fairly common symptom is important. Also the fact that it does escalate over time, so if you detect it, be aware that this could be a Friday night phone call that's quite unpleasant in a short amount of time. That can evolve from something that's described as so-called benign, become something that's very hair-raising to the patient and to their family as well. And it tends to persist. This is not a symptom that is going to be a transient phenomenon. It escalates and persists over time.
Thank you, Dan. Thank you, Neil, for being here today.
It's been a pleasure.
It was really fun.
And thank you for participating in this activity. You may now revisit those questions presented at the beginning of the activity to see what you've learned by clicking on the Earn CME Credit link. The CME post-test will follow. Please also take a moment to complete the program evaluation at the end.